So we're here to speak about a method that you will find in old osteopathic literature. The places that I'm referring to specifically would be a book by Dain as well as a book by Ernest. So what they're speaking about in the method that they describe is essentially creating extension in the thoracic region. Now they talk about having the patient in a seated position and the practitioner standing. The way that it's spoken about by Tucker is essentially to have the practitioner slide their arms underneath the patient's arms, have the patient's head on their midline, and then create extension that way. So I'll show you what that looks like, and then as far as task is concerned, there's a photograph in the book, and I'll link to that. And the photograph shows it a little bit differently. It's essentially the same hold, but what Tasker has the practitioner do, or the patient do rather, is take their head off of midline. So just as an initial kind of demonstration, what we'll do is we'll show you what it looks like as far as Tucker is concerned. So as I step in, I have to come down just because of the height of my patient, the height of the stool that I'm using, as well as where my sternum happens to be. If I just slide right in right now, the patient's forehead and nose will be in my abdomen, or the soft part of my abdomen. I'd rather have them on my sternum, so I have to just drop down a little bit. And we have them right here, and then I sneak around, and then what they're talking about is basically doing this. Now you can see that based on the size of myself and the size of my patient, I can't get around to the vertebrae. I can get to the ribs, right? This is not particularly ideal in this case. So we consider that the method may have some validity, but for me to perform it in a situation where the patient is a different size than me, or a size where I can't effectively get around. So let's just say I want to make an adjustment, and to get around, I have to really kind of come right in here and stand like this. Now for myself, there's a lot of effort involved in that, and I can't get up here, okay? So whether we use Tucker's method or Tasker's method doesn't necessarily make much of a difference. Before we move on to show a possible modification to this, we want to just talk about one of the things that's occurring here. The concept of contact is control, so getting in tight to the patient, wrapping around the patient, so essentially having a very full hold around their thorax, around the mid-axillary line. My forearms are wrapping around, my hands are wrapping around. There's a fair amount of contact. The challenge is because of height differentials and size of my arms, and the fact that I have to reach around. So there's a fair amount of contact, but the challenge becomes that the effort and the load are fairly separated. They're kind of far apart. It becomes a bit of an issue. A modification that I've seen over time that many people like to use, what they do is some people will call it essentially I Dream of Jeannie, the I Dream of Jeannie pose, but if you've never seen that show, or you're not of the right age, you don't get the reference. It's kind of a waste of time. But essentially what it is the patient crosses their arms like this, and then they place their forearm on their forehead. So we'll go like this, forearm on your forehead. So that already lifts the shoulder, so it kind of gets that out of the way. And then what I can do is, without having the patient's head on my sternum, which for some people is uncomfortable, whether it's the patient or the practitioner, here I can reach around it slightly easier, and I can stand up. Now this becomes less cumbersome, so this is a reasonable change, but to create actual thoracic extension, I have a bit of an issue. So you'll see, if you pay attention, you'll see how far I might be able to move the patient, right, into extension. We'll see what that looks like. It's not perfect, but we're trying. Now what we do is we kind of look at here, and then what we're going to have you do, keep your arms up, sit up as tall as you can, stick your tummy forwards, and you see how much extension he can create, right, how far he can go, and then relax. Now I have to glide him forwards to even come close. I cannot create the same amount of thoracic extension for my patient in this situation. So the method, while possibly useful depending on how essentially immobile a thoracic column may be, a thoracic vertebral column may be, it generally tends to be cumbersome. So whether the patient was sitting up higher or lower or what have you, if I reach around under the axilla, under the armpits, I have a hard time. It's quite cumbersome. If I make this adjustment, we go into that pose where the patient essentially has their forearms, brings the arms up. This, bringing the shoulders up, seems to help create some mild thoracic extension as a beginning point, or as a starting point. However, the challenge becomes, I am incapable with that hold in most cases, not exclusively, in most cases, of creating as much thoracic extension as the patient can create actively. So we have a bit of an issue. The method can be useful, all right? So again, we're highlighting this to identify a few things, that the method does exist. It exists in old osteopathic literature to identify that There are multiple ways to do it. The idea is to create thoracic extension with the patient in the seated position. There are problems with it. It's quite cumbersome. There are modifications to it, right? Bringing the arms up, biasing towards extension as a starting point. The most kind of complete correction we can make is we're going to have you do this. Okay, sit up as tall as you can. Now, as he sits up as tall as he can, I can come in. So he's already biased towards the position, towards extension, and I can move through here. Now, one of the other challenges, if we think about patient positioning, we prefer, as far as choosing the position, we prefer the anatomy to be exposed, free to move in the plane required, both of which are true in this case, and preferably visible. Now, while being visible is not a necessity, it's preferable. So my challenge is, although I can feel the vertebral column, I may not have as great an understanding of what's going on with it. So overall, this method, the idea of highlighting this method, of displaying this method, is to show you that it exists again, that it can be useful, but it is cumbersome, and there are corrections. So the two biggest corrections are bringing the arms up towards the patient's forehead. If they can, if a patient has a shoulder problem, they may not be able to do that. You probably just want to choose another method altogether. And then biasing the patient actively towards extension. So you have them sit up as tall as they can. You can tell them to stick their abdomen forwards, and that creates general extension. And then you can work from there. You don't have to pick them up into extension. So we also see the concept of contact as control and control as safety. We see concepts of patient positioning. We see the idea of negative space. So the space between us is unstable. For me to get fairly close to the patient, sometimes I'm crowding them quite a bit. Their face is going into my body. That can be quite uncomfortable for some patients. As Tasker talks about, you can put the patient off, or the head off midline, and even then that's not ideal. So if the patient puts their forearms up, it essentially acts like a buffer between yourself and the patient. So there's a lot of positive things to be found here if done appropriately and if done on purpose. So you have to understand that it is very difficult to lift a patient from a relative neutral position, their relative comfortable neutral position, into as full extension as should be available, and that it is cumbersome. You have to do a lot of lifting, but you can correct that. You bring their arms up, if their shoulders are okay, you have them sit up first, and then the work becomes easier, but still quite cumbersome, still difficult. So again, overall, now you've seen this method. You might have seen it before. You've seen it, and we'll link to where you can read about it in early osteopathic literature. But it also allows us to talk about a method that might be popular or might be preferred by some practitioners. So when you see it, you can understand that why they like it. You can understand that it can be useful, but you understand that you might need to make corrections to make it as useful as it could be.